This pod is brought to you by the Neutrophil's enigmatic blue-green crystal inclusions. These aren't just mere cellular anomalies, they are tiny iridescent omens, appearing mysteriously within your valiant neutrophils like strange otherworldly gems. Their very presence whispers of an impending profound systemic imbalance, as if the cell itself is manifesting a dire warning from the deepest, most chaotic corners of the body's internal machinery. They are the beautiful, chilling heralds of a storm gathering within.
Welcome to Fine Focus, where we move beyond the instrument printout and into the intricate world of morphology.
Here, we believe every cell tells a story, and it's our job to read it.
Today, we're delving into a topic that's the stuff of hematology legend. It's a finding so rare, you might go your whole career without seeing it, but so clinically significant that missing it isn't an option. It's dramatic, it's foreboding, and it has some equally dramatic nicknames.
That's right. We're talking about the so-called green crystals of death, or as they're more formally known, critical blue-green inclusions. This is one of those findings where the MLS isn't just generating data, you're delivering a piece of information that can, in real time, change the entire clinical picture for a critically ill patient.
Absolutely, and our goal today is to give you, our fellow MLS professionals, a complete briefing on this phenomenon. We're going to be grounding our discussion in an excellent recent paper from the journal Laboratory Medicine by Antonio Sierra Rivera and his colleagues, titled Blue-Green Inclusions in Neutrophils and Monocytes as a Sign of Imminent Death. It's a fantastic case series that adds some really important data to what we know.
We'll break down what these inclusions look like morphologically, explore the terrifying pathophysiology they represent, and discuss why the laboratory scientist at the microscope is the one and only line of defense for detecting them. This is a story about the irreplaceable value of the peripheral blood smear.
So let's start at the bench and set the scene. You get a stat CBC from the ICU on a patient who is, clinically speaking, circling the drain. Your analyzer flags for a smear review. You dip your slide, put it on the scope, and what do you see?
The first thing you notice is that this isn't a normal smear. You're likely seeing other signs of severe illness, maybe toxic granulation, Dolly bodies, vacuolization, but then you spot it. In the cytoplasm of a neutrophil, there's an inclusion that just doesn't belong. It's not a Dolly body, which is usually a pale gray-blue patch. This is different. The Sierra Rivera paper describes it perfectly as blue-green, refractal, and irregularly contoured.
Refractal is such a key word there. It means it shimmers, it catches the light as you fine focus up and down. It's not a flat, dull stain. The paper also notes they can be single or multiple, and they vary in size and shape. You might see a small shard or a larger, jagged clump.
And they're primarily found in neutrophils. The Sierra Rivera study found them in 100% of their cases in neutrophils and less frequently in monocytes in only about 2 of their 13 cases. The literature suggests there seems to be a preferential uptake by neutrophils. You'll typically only see them in a small fraction of the cells, which is another crucial point. We're talking 1% to 5% of neutrophils. This isn't a finding that screams at you from low power. You have to be hunting for it in the feathered edge.
It's a finding that truly requires a trained eye and a high index of suspicion. So we have this vivid, shimmering, blue-green crystal. What is it? What's the composition?
The prevailing theory, which the article supports, is that these inclusions are composed of lipofuscin or a similar lipid-rich pigment. Lipofuscin is often called the wear and tear pigment. It's an aggregate of oxidized proteins and lipids that builds up in cells over time, especially in long-lived cells like neurons or cardiac muscle. But in this context, it's not about aging. It's about acute, catastrophic cellular damage.
And that brings us to the clinical significance. Why are these crystals appearing, and why are they associated with such a grim prognosis?
The connection is incredibly strong and consistent across the literature. These inclusions are a marker of severe acute ischemic liver injury. The proposed pathophysiology is quite logical. When a patient is critically ill from sepsis, shock, massive trauma, you name it, they can suffer from hypoperfusion, where not enough oxygenated blood is reaching the organs. The liver is particularly vulnerable to this hypoxic injury.
So the liver cells, the hepatocytes, begin to die en masse. This is called hepatic necrosis.
Exactly.
As these hepatocytes necrose, they break apart and release their contents into the bloodstream. This includes their accumulated lipofuscin pigment. From there, it's a cleanup job. Circulating phagocytes, our neutrophils and monocytes, encounter this debris and engulf it. The lipofuscin is then visible in their cytoplasm as these distinct blue-green inclusions. So when you see these crystals in a neutrophil, you are essentially seeing a tombstone for a dead liver cell.
That is a chillingly effective way to put it. You're not just looking at a blood cell, you're seeing the fallout from a major organ failure event happening elsewhere in the body. The Sierra Rivera paper does a great job of showing the diversity of causes that can lead to this final common pathway of liver failure.
It really does. Their case series of 13 patients had a huge range of initial diagnoses. They had patients with COVID-19 pneumonia, cocaine intoxication, hypovolemic shock, decompensated heart failure, septic shock, and hemorrhagic stroke. It wasn't one specific disease. It was any severe condition that was enough to push the liver over the edge.
And this is where the rest of the lab data comes in and paints a terrifyingly clear picture. The paper provides a table of the biochemical results for these patients at the time the inclusions were found. The numbers are staggering.
They are. Let's talk about the liver enzymes. The median ALT was over 2,000 UL. The upper limit of normal is around 40. The median AST was over 3,500 UL when it should be under 30. These are not subtle elevations. This is a signal of massive, widespread hepatocyte necrosis.
The lactic dehydrogenase is also through the roof in all cases, with a median over 11,000 UL. And another consistent finding they highlight is lactic acidosis. Most of the patients had a low blood pH and significantly elevated lactate levels. The paper makes the point that several studies have shown that when liver failure is combined with lactic acidosis, the mortality rate skyrockets. It's a double whammy of metabolic collapse.
This is what makes the Sierra Rivera paper so valuable. It's not just describing the morphology, it's presenting a complete, data-rich clinical and laboratory picture. This was a retrospective study at a single university hospital, and they found 13 cases over the course of just 1 year, from March 2021 to March 2022. The authors note that this makes it one of the largest, if not the largest, case series to date, which tells you how rare this finding really is.
Let's get to the number that gives these crystals their ominous nickname. What did the study find regarding mortality?
The mortality rate in their cohort was 84.6%. 11 of the 13 patients died. And even more stark is the speed of the decline. Of the 11 patients who died, 8 of them, the vast majority, died within 24 hours of the lab detecting these inclusions. 2 others died within 48 hours. This isn't a prognostic indicator for weeks or months down the line. It is, as the title of the paper suggests, a sign of imminent death.
It's a 5-alarm fire of a lab result, and this brings us to what I think is the most important part of the discussion for our audience, the role of the MLS and the laboratory in this scenario. One of the most fascinating parts of this paper's discussion section is the debate on how or even if to report this finding.
Right. They bring up the point made by another researcher, Gorup, who had suggested that maybe these inclusions shouldn't be reported as a sign of poor prognosis. The concern was that such a dramatic report could lead to a clinical team to alter their decisions, perhaps towards withdrawing care, potentially harming a patient who might have had a chance to recover.
It's a valid ethical concern, but the authors of this paper, Sierra Rivera and colleagues, take a strong stance on the other side. They argue that reporting is not only appropriate but essential, and they have the data to back it up. They point out that in 7 of their 13 cases, that's over half, and it included the 2 patients who ultimately survived, the emergency physicians were unaware that the patient was in acute liver failure until the laboratory called them about the inclusions.
Let that sink in. The first sign that the patient's liver was collapsing didn't come from a physical exam or a specific test order. It came from a routine CBC smear review by a laboratory scientist who spotted a few green crystals. The paper states that the lab's notification facilitated urgent measures to restore liver function through close patient monitoring and control. The lab wasn't delivering a death sentence, it was raising a critical life-or-death alarm that wasn't on anyone else's radar.
This is the absolute peak of being a diagnostic consultant. It completely refutes the idea of the lab as just a black box that spits out numbers. And it highlights something else the paper confirms. Automated analyzers are blind to this. The authors explicitly state that no relevant findings were observed in the WBC scattergram. The only way to find this is with a well-made slide, a good microscope, and a stilled morphologist.
So let's synthesize this for the MLS on the bench. What are the key takeaways? First, be hypervigilant on smears from critically ill patients. If it's coming from the ICU, your spidey senses should already be tingling.
Second, know what you're looking for. Blue-green, shimmering, irregular inclusions in neutrophils.
Third, understand their potential significance. If you see them, your next thought should be ischemic liver failure. You should immediately check the patient's history for their recent liver enzymes and lactate if they're available. You are looking for a pattern of evidence.
Fourth, and this is non-negotiable, this finding requires an immediate critical value phone call to the physician or nursing staff. This isn't something that can wait for the doctor to see it on rounds tomorrow morning.
Given the data from this paper showing death often occurs within 24 hours, time is of the essence. You need to be prepared to describe what you're seeing and explain its clinical association. Saying, I'm seeing rare blue-green inclusions in the neutrophils which are strongly associated with acute liver injury, is a powerful, actionable statement.
And it's also important to know what to differentiate them from, as the paper mentions. You don't want to cause a panic over something else. These are not Dolly bodies. They're not cryoglobulin precipitates, which are usually extracellular. They're not the inclusions of a May-Heglin anomaly. Their unique color and refractile nature are key. If you're unsure, the best practice is to get a second opinion from a senior laboratory scientist or a pathologist.
Absolutely. To pull it all together, we started with this incredibly dramatic finding, the green crystals of death. And we've seen through the excellent work of Sierra Rivera and colleagues that this isn't just hematology folklore. It's a real, albeit rare, morphological sign of a specific and catastrophic event, acute ischemic liver failure.
It's a perfect illustration of our value. We, as laboratory scientists, sit at the intersection of technology and human expertise. And sometimes it's that human expertise, the ability to recognize a 1% finding on a glass slide and understand its profound meaning, that makes all the difference. We are reading a story of cellular devastation and sounding the alarm.
Well said. The next time you see a critical smear from the ICU, hopefully you'll have this in the back of your mind. You might just be the one to spot those few shimmering green crystals and provide the clue that no one else has seen.
A powerful place to end for today. A huge thank you to the authors of the paper for their work in documenting these cases so thoroughly. We'll see you next time.